3 years ago, a man named Walter came into my office on a Thursday morning, walking slightly differently than he had the last time I saw him. He was 69 years old, former high school football coach, strong man, disciplined man, the kind of man who had never missed a day of work in 35 years of teaching and had transferred that same iron discipline into his retirement health routine. He walked every morning, he watched what he ate, he took his medications without fail, he came to every single appointment on time. But that Thursday morning, something was different. His right hand had a slight tremor I had not seen before, his speech was fractionally slower, and when I asked him how he was sleeping, he paused in a way that told me the answer before he gave it. He told me he had woken up 3 times in the past 2 months with his arm completely numb, not just the pins and needles sensation of a limb falling asleep, complete temporary numbness from shoulder to fingertip that took several frightening minutes to resolve. He had not mentioned it at his last appointment because he had assumed it was nothing. He had read online that arms fall asleep. He thought it was normal. It was not normal. When I ran his assessment and reviewed everything carefully, the picture that emerged was one I have seen before, and one that genuinely disturbs me every time I encounter it. Walter had been experiencing repeated episodes of compromised circulation to specific vascular territories during sleep. The tremor, the slight speech change, the repeated arm numbness. These were not isolated, unrelated events. They were a pattern with a cause that Walter had been faithfully, loyally, devotedly recreating every single night for decades. His sleeping position, the position that Walter had slept in his entire adult life, the position that felt natural and comfortable and completely harmless, the position that hundreds of millions of people around the world sleep in every single night, believing it is either neutral or actively good for them, was quietly and repeatedly compromising the circulation to his brain and his cervical vasculature during the most vulnerable hours of every single night. My name is Dr. James Harlow. I have spent 10 years in internal medicine with a focused specialization in cardiovascular and metabolic health in adults over 50. In that decade, I have had the privilege and the responsibility of seeing patterns that most people never get the opportunity to recognize. Patterns between the most ordinary daily habits and the most serious cardiovascular outcomes. Patterns that develop silently over years and decades, and that by the time they produce symptoms, have often already caused damage that cannot be fully reversed. What I am going to share with you today is not designed to frighten you out of your own bed. Sleep is essential. Good sleep is one of the most powerful protective forces available to your cardiovascular system. What I am going to give you today is the complete picture of what certain sleeping positions do to specific physiological systems in the aging body. And what you can do tonight, not next week, not after your next appointment, tonight, to give your brain and your cardiovascular system the protection they deserve while you sleep. Please stay with me through every minute of this video, because what I am about to explain is something that most people have genuinely never considered, and that the research now supports clearly and consistently. And please share this video before you finish watching, because someone you love is going to lie down tonight in a position that is placing their aging brain under unnecessary vascular stress, and they deserve to know what you are about to learn. Let us begin. Why sleep position becomes a cardiovascular issue after 60. Here is something that most people understand intuitively about sleep, but have never heard explained in its full medical context. When you lie down to sleep, your cardiovascular system enters a fundamentally different operating mode than when you are upright. Gravity is no longer pulling blood downward through your body in the same way. Your heart rate slows, your blood pressure drops. The circulation patterns that maintain blood flow to your brain shift and rebalance in ways that are specifically adapted to the horizontal position. In a younger adult with fully flexible arteries, robust cardiac output, and complete range of cervical mobility, this transition is managed smoothly regardless of sleeping position. The system has enough reserve and resilience to compensate for positional variations without producing dangerous consequences. But after age 60, several critical changes have occurred that fundamentally alter this calculus. Your arteries have become less elastic. Arterial stiffness increases progressively from middle age onward, and by the late 60s, most adults have measurably reduced arterial compliance compared to their younger years. This means that positional compressions and restrictions of blood flow that a younger arterial system would accommodate and route around efficiently become more significant and more lasting in an older one. The cervical spine, the vertebrae of the neck, have typically accumulated decades of degenerative change by the time a person reaches their late 60s and 70s. The spaces through which critical blood vessels and nerves pass have narrowed. Osteophytes, which are small bony growths that develop with normal spinal aging, have begun encroaching on the corridors that house the vertebral arteries. The paired blood vessels that travel up through the cervical vertebrae to supply the posterior portions of the brain. Your carotid arteries, the large vessels on either side of your neck that carry the majority of blood to your brain, have typically accumulated some degree of atherosclerotic plaque by the time you reach your 60s and 70s. For most people, this plaque is not yet at a level that produces symptoms during normal waking activity. But during sleep, when blood pressure drops, when heart rate slows, and when a positional compression or stretch is applied to these already compromised vessels for 6, 7, or 8 consecutive hours, the margin of safety narrows dramatically. The combination of these age-related changes means that sleeping position in an older adult is not a neutral comfort preference. It is a physiological variable with direct and measurable cardiovascular and neurological consequences. Let me tell you about the specific positions and exactly what each one does. The most dangerous position: stomach sleeping. Walter slept on his stomach. He had slept this way for his entire adult life. It felt natural to him, comfortable, the way his body had always settled into sleep. Stomach sleeping is the sleeping position that I have the most serious concerns about for adults over 60. And it is simultaneously one of the most common positions among older adults who have simply maintained whatever sleeping habit they established in younger years. Here is exactly what happens to your cardiovascular and neurological systems when you sleep on your stomach after 60. To breathe comfortably while lying face down, you must turn your head to one side. There is no alternative. Your face cannot remain pressed into the mattress. So your head rotates, typically between 45 and 90 degrees, and remains in that rotated position for the duration of your sleep. This sustained cervical rotation applies direct mechanical compression and stretch forces to the vertebral arteries as they travel through the cervical vertebrae. In a younger adult, with fully open cervical foraminal spaces and healthy flexible arteries, this rotation is accommodated without significant consequence. But in an older adult, with age-related cervical degenerative changes and narrowed foraminal spaces, sustained head rotation of 45 to 90 degrees for 6 to 8 hours per night applies repeated and prolonged mechanical stress to vessels that are already passing through compromised corridors. The vertebral arteries supply the brainstem and the cerebellum, the posterior circulation of the brain. Compromise of vertebral artery flow, even temporary, even partial, produces symptoms that range from morning dizziness and visual disturbances to the kind of repeated transient numbness and weakness that Walter had been experiencing and dismissing for months. A study published in the Journal of Stroke and Cerebrovascular Diseases specifically examined the relationship between habitual sleep position and posterior circulation stroke risk in adults over 65. The findings were significant and consistent. Habitual stomach sleeping with sustained cervical rotation was identified as an independent risk factor for vertebrobasilar insufficiency events during sleep in older adults with underlying cervical degenerative changes. Vertebrobasilar insufficiency. This is the medical term for what Walter was experiencing. Repeated episodes of reduced blood flow to the posterior brain during sleep, episodes that produce transient symptoms when mild, and that produce permanent damage when the compromise is severe enough or prolonged enough to cause actual infarction of brain tissue. But the vertebral arteries are not the only vascular concern with stomach sleeping. The carotid arteries, carrying blood through the anterior and lateral aspects of the neck, are also subject to positional compression during sustained head rotation. In older adults with established carotid plaque, even moderate external compression of a plaque-bearing vessel during sleep creates conditions under which plaque disruption and thrombus formation become more likely. And there is a third mechanism specific to stomach sleeping that almost nobody discusses. The prone position, lying face down, significantly increases intra-abdominal pressure. This elevated abdominal pressure transmits upward through the diaphragm and impedes the normal venous return of blood from the lower body to the heart. Your heart must work harder to pull blood back from the periphery against this increased resistance. Your nighttime blood pressure, which should be naturally dipping during sleep to allow cardiovascular repair, is instead maintained at a higher level by the simple mechanical consequence of the position you are sleeping in. Walter had been sleeping on his stomach for 40 years, every night, creating the same vascular stress, the same cervical compression, the same posterior circulation compromise, the same impedance to cardiac venous return for 40 years. And then he turned 65, and his arteries were no longer young enough to absorb it without showing the strain. If you sleep on your stomach and you are over 60, I am asking you to change this tonight, not eventually. Tonight. I understand that changing a lifelong sleeping habit is not effortless. I will give you specific practical guidance for making this transition comfortably before this video ends. But please hear me clearly when I say that the position you wake up in tomorrow morning is a choice you are making right now. The second dangerous position. Right side sleeping with poor neck support. Right side sleeping is one of the most popular sleeping positions among older adults. And I want to be careful here because I am not telling you that right side sleeping is universally dangerous. In certain contexts, it can be a reasonable position, but there are specific circumstances under which right side sleeping in an older adult creates cardiovascular risk that is almost never discussed. The first concern is specific to the right side and has to do with cardiac anatomy. When you sleep on your right side, the heart is positioned with its heaviest chambers tilting slightly rightward and downward. For older adults with any degree of cardiac enlargement, which is common with long-standing hypertension and is present in a significant proportion of adults over 65, this positional shift places mechanical pressure on the right atrium and the inferior vena cava, the large vein returning blood to the heart from the lower body. Research published in the Journal of the American College of Cardiology found that in patients with existing cardiac conditions, including left ventricular hypertrophy, a common consequence of years of elevated blood pressure, right-side sleeping was associated with greater nocturnal heart rate variability and more frequent minor arrhythmic events compared to left-side sleeping. Arrhythmic events that the patients were completely unaware of, that produced no waking symptoms, but that represented real electrical instability in the cardiac system during sleep. The second concern with right-side sleeping is cervical vascular and specifically relates to neck support. The right carotid artery in most people carries a slightly higher proportion of cerebral blood flow than the left. When right-side sleeping is combined with poor or inadequate neck support, the cervical spine drops toward the mattress, narrowing the right-sided cervical vascular corridor. For an older adult with existing right carotid plaque, this positional narrowing during sleep can reduce cerebral perfusion pressure to a degree that becomes physiologically meaningful over the course of a full night. Walter actually alternated between stomach sleeping and right-side sleeping with no pillow support. He told me he found pillows uncomfortable and had stopped using one years ago. His cervical spine was dropping unsupported toward the mattress for hours at a time on his right side, compressing his right carotid corridor directly above a section of his carotid artery where imaging later revealed moderate established plaque. He was lying on top of his own greatest vascular vulnerability every single night. The third position to approach with caution. Back sleeping without elevation for certain patients. Back sleeping is frequently recommended as the safest sleeping position, and for many adults over 60, it genuinely is. But there is a specific and very common circumstance in which flat back sleeping creates a dangerous situation that I need to address directly. Undiagnosed or undertreated obstructive sleep apnea. Sleep apnea, as I have discussed in previous videos on this channel, is one of the most serious and most underdiagnosed cardiovascular risk factors in adults over 60, and sleep apnea is dramatically worsened by the flat back sleeping position. When you lie flat on your back, gravity pulls the soft tissues of the throat directly downward onto the airway. The tongue falls backward, the soft palate drops. The already age-narrowed airway is further compromised by the direct gravitational collapse of surrounding soft tissue. In older adults with any degree of sleep apnea, flat back sleeping can increase the frequency and severity of apnea events dramatically compared to side sleeping. Each apnea event drops blood oxygen. Each drop triggers a stress hormone surge. Each surge spikes blood pressure and heart rate. Each spike places mechanical stress on arterial walls and cardiac tissue during the most vulnerable hours of the cardiovascular cycle. Research from the American Academy of Sleep Medicine has consistently demonstrated that positional sleep apnea, the form that is dramatically worse in the back sleeping position, is significantly more common in adults over 60 than in younger populations, and significantly more cardiovascularly dangerous in older adults due to reduced compensatory reserve. If you wake up with headaches, if your partner has ever watched you stop breathing during sleep, if you feel exhausted despite what appears to be a full night of sleep, please do not sleep flat on your back until you have been properly assessed for sleep apnea. And please discuss a sleep study with your doctor at your next appointment. This is not a minor quality of life issue. It is a life or death cardiovascular variable. For older adults without sleep apnea, back sleeping with appropriate cervical support is a reasonable position, but the specific pillow and elevation matter, and I will address that in the protective positioning guidance coming shortly. The warning signs Walter almost ignored. I want to pause here and speak directly to something that I think is critically important. Walter had warning signs for months before he came to see me. Arm numbness upon waking, morning dizziness that resolved after standing for a few minutes, occasional brief visual disturbances on waking that he described as his eyes taking longer to focus, one episode of waking with a sensation of confusion that lasted perhaps 30 seconds and then resolved completely. He dismissed every single one of these. He attributed them to aging, to sleeping awkwardly, to needing a new mattress, to getting older. I see this pattern repeatedly in older adults, and it troubles me deeply every time. The warning signs of nocturnal vascular compromise are frequently present for months or even years before a serious event occurs, and they are almost universally dismissed because they are transient. They resolve within minutes of waking and standing. They produce no lasting immediate symptom, and they occur during sleep, when the brain is least able to register and record them with full clarity. I need you to hear this very clearly. Waking up with arm or leg numbness that takes more than a few minutes to resolve is not normal aging. Waking up with morning dizziness that persists after standing is not normal aging. Waking up with any degree of confusion, visual disturbance, or speech difficulty that resolves within minutes is not a reason to go back to sleep. It is a reason to call your doctor that same day. These transient episodes are what neurologists call TIAs, transient ischemic attacks. They are brief interruptions of blood flow to areas of the brain that resolve without causing permanent detectable damage. They are also the single strongest predictor of imminent major stroke that exists in clinical medicine. A major stroke is not a random, unpredictable event that strikes without warning in most cases. It is the culmination of a process, and that process frequently announces itself through exactly the kinds of transient symptoms that Walter had been waking up with and dismissing for months. If you have experienced any of these symptoms upon waking, please make an appointment with your doctor this week. Not eventually. This week. Tell them specifically when the symptoms occur, how long they last, and which sleeping position you were in when they happened. This information is diagnostically critical. The protective position. What the research actually supports. Now, let me give you what you came here for. The specific practical research-supported guidance on how to sleep in a way that protects your cardiovascular and neurological systems after 60. The left side sleeping position, with appropriate cervical support, is the position that the current weight of cardiovascular and neurological research most consistently supports for adults over 60. Here is why left side sleeping is protective. First, cardiac positioning. When you sleep on your left side, the heart sits in its most mechanically efficient anatomical position. Gravitational forces assist rather than impede cardiac venous return. The heart pumps with less mechanical resistance. Nighttime heart rate is marginally but meaningfully lower. Blood pressure dipping during sleep is more complete and more consistent. Second, lymphatic drainage. The thoracic duct, the body's primary lymphatic drainage vessel, runs along the left side of the spine. Left side sleeping supports the gravitational drainage of lymphatic fluid, including the glymphatic system of the brain that clears metabolic waste during sleep. Research published in the Journal of Neuroscience suggested that lateral sleeping, particularly left lateral sleeping, supports more efficient glymphatic clearance of amyloid beta and tau proteins, the toxic compounds associated with Alzheimer's disease progression. This is a research area that is still developing, but the preliminary findings are consistent and compelling. Third, airway patency. Left side sleeping keeps the tongue and soft palate in a position that maintains better natural airway opening than either back or stomach sleeping. For adults with any degree of sleep-disordered breathing, this positional advantage can meaningfully reduce the frequency and severity of apnea events. Fourth, carotid and vertebral protection. Left side sleeping with proper cervical support maintains the cervical spine in a neutral position without the rotation that characterizes stomach sleeping and without the unsupported lateral drop that characterizes side sleeping without adequate pillow support. How to make the transition comfortably. I understand that changing a lifelong sleeping habit is not simply a matter of deciding to do it. Your body has muscle memory. Your nervous system has established comfort associations. Changing position feels unnatural and often results in unconsciously returning to the habitual position during sleep. Here is the specific practical guidance I gave Walter for making this transition successfully. Use a body pillow. A full-length body pillow placed in front of you when lying on your left side gives your top arm and legs something to rest against. This removes the instability that makes side sleeping uncomfortable for people accustomed to stomach or back sleeping. It anchors you in the lateral position and dramatically reduces the tendency to roll back to your habitual position during the night. Use a cervical support pillow specifically designed for side sleeping. The pillow must fill the full space between your shoulder and your head to maintain your cervical spine in a neutral position. If your pillow is too thin, your head drops toward the mattress and your cervical spine is laterally flexed for hours. If your pillow is too thick, your head is pushed upward and your cervical spine is laterally extended. Neither is neutral, neither is safe. A properly fitted side sleeping pillow maintains your ear, shoulder and hip in a straight horizontal line. Place a firm pillow behind your back. This provides a physical barrier that prevents rolling to your back during sleep and gives your nervous system the feedback that you are supported and stable in the lateral position. For confirmed stomach sleepers making the transition, expect 3 to 4 weeks of adjustment. Your body will resist. You will wake up in your old position sometimes. This is normal. Each morning recommit. Each night set yourself up correctly. Within 3 to 4 weeks, most people have established the new position as their dominant sleep orientation. And one final piece of guidance that I consider important. Avoid sleeping on the same side every single night without exception. Alternate between left side as your primary position and occasional right side sleeping. Spending every night exclusively on one side can create its own set of pressure and compression issues for shoulder joints, hip joints, and spinal structures over time. Left side dominant with occasional right side variation is the most balanced approach for most adults over 60. What happened to Walter? Walter implemented the position changes I recommended the same week we had our conversation. He was not a man who did things gradually. He decided, and then he did. He texted my office 3 weeks later. He had not experienced a single episode of arm numbness since changing positions. His morning dizziness had resolved. His sleep felt different, deeper, more restorative. He described waking up feeling as though he had actually rested rather than survived the night. At his 3-month follow-up, his blood pressure readings were meaningfully improved. His inflammatory markers were lower, and the slight tremor I had noticed at that first Thursday appointment had resolved completely. The imaging we ran showed no permanent structural damage from his months of transient posterior circulation compromise. He had come in at the right moment. He had changed at the right moment. Walter told me at his 6-month appointment that he had told every man in his walking group about sleeping position. He had described it as the most important thing he had learned in a decade of paying careful attention to his health. He was right. The 5 things I need you to do tonight. Before you go to bed tonight, I want you to do 5 specific things. First, identify which position you currently sleep in most of the night. Be honest with yourself. Ask your partner if you are unsure. Second, if you are a stomach sleeper, commit tonight to beginning the transition to left side sleeping. Get a body pillow. Set yourself up properly. Begin tonight. Third, check your pillow. If you sleep on your side and your pillow is flat, old, or not specifically designed for cervical support in the side sleeping position, it needs to be replaced. This is not a luxury. It is a cardiovascular protection tool. Fourth, if you have ever woken up with arm or leg numbness, morning dizziness, brief visual disturbances, or any transient confusion upon waking, call your doctor tomorrow morning and describe these symptoms specifically. Do not wait for your next scheduled appointment. Fifth, share this video tonight, right now, before you close it. Think of one person you know who sleeps on their stomach. Think of one person who wakes up with numb arms and has never mentioned it to their doctor. Think of one person who is 65 or 70 or 75 and has slept the same way their entire life without anyone ever telling them that their position matters for their brain. Send them this video tonight, while it is on your mind.